Well, I guess we will start because I know your time is valuable. I'm Julie Haluska, the KHAM webinar chair, and welcome to the webinar series with Kern Medical and Valer Health. And I am with Point Care, and I'm going to turn it over to Phil Dolan, the Chief Growth Officer at Valer, to make the introductions. Phil?
Great. Thanks, Julie. Good afternoon, everybody. Welcome to today's webinar, Meeting and Exceeding Industry Benchmarks, Kern Medical's Prior Authorization Triumph. Again, like Julie said, my name is Phil Dolan. I'm Chief Growth Officer at Valer. We are a provider of automation technology that speeds and simplifies prior authorization management. Before we get underway today, I'll share a few housekeeping notes. First, today's webinar is designed to help educate you on an approach to improving your prior authorization management. There is no product demo per se, but you'll hear a lot about the way Valer has worked for Kern Medical. If you have interest in Valer's solution, you can request follow-up in the survey that you'll receive at the end. Even if you're not looking for help with prior authorization management, we'd love your feedback on today's webinar. Survey respondents will be entered into a drawing for a $50 Amazon gift card, and we'll let you know who won in our follow-up email. We invite your questions throughout today's webinar, and we'll address as many as we can at the end. You'll find a Q&A button at the bottom of your screen, and I will read your questions to our panelists. You may also use the chat button if you want to share any thoughts with other attendees or our panelists. Finally, we'll be recording today's webinar. We'll make today's webinar recording and slides available, and we'll send both to you by next Wednesday, May 22nd. I'd now like to introduce you to today's speakers. First, Dr. Steve Kim is a co-founder and the CEO at Valer, again, a provider of solutions that automate prior authorization and referral management. With more than 20 years of medical experience and a passion for studying value-based care outcomes, Steve's expertise has been vital in navigating the evolving complexities of the healthcare industry and identifying the administrative roadblocks and bottlenecks delaying access to care. Before Steve's transition into entrepreneurship, he was an assistant professor of urology at the University of Southern California's Keck School of Medicine. While at Keck, Steve also served as the director of clinical research informatics for Children's Health Hospital Los Angeles, in addition to practicing pediatric urology. Every time I read your bio, Steve, I wonder when you ever slept, but that's an aside. Steve earned his undergraduate degree at Yale University and was awarded his medical degree from Cornell University Medical College. Edward Dinh serves as Senior Director of Patient Access for Kern Medical, a 222-bed public hospital providing Level 2 trauma services to the Bakersfield, California region, and a teaching hospital affiliated with UCLA and Ross University. Mr. Dinh has over 43 years of revenue cycle experience, including leadership and consulting roles in patient accounting and patient access for Cantu Management Group, Optum 360, Dignity Health, HCA, Tenet, and other community hospitals. Edwards recently served 5 years as vice president of KHAM. He is a past recipient of the Carl Satterfield Award in 1999, and Mr. Dinh was also a member of NAHAM. Edward received his CHAM in 2003. He is a past presenter at KHAM, Cerner Oracle's user group meeting, NAHAM, and Clarivate conferences. When he's not working or performing community service, Edward enjoys wine tasting, hiking, concerts, various festivals, and spending time with family, especially his 6 grandkids. You sound like somebody I want to spend more time with, Edward, for sure. Amber Teves is an accomplished revenue cycle manager and a certified UX and UI designer. With a unique blend of skills, Amber identifies opportunity, crafts innovative solutions, and drives success. Her focus on healthcare IT solutions is remarkable, with a strong passion for data, emerging AI technologies, and all things related to healthcare technology. Amber began her revenue cycle journey in 2008, building a solid foundation serving in various leadership roles with Optum 360, Adventist Health, and most recently, Kern Medical. Amber is actively engaged with Kern Medical's integration automation solutions for prior treatment authorizations, NSA compliance, Oracle Cerner upgrades, and is an integral member of the team responsible for vendor compliance, acquisition, and replacement. Amber's dedication in support of key hospital service lines exceeds expectations. She knows how to optimize applications under her jurisdiction and is responsible for data tracking and reporting of revenue cycle KPIs. When away from work, Amber is actively engaged in the development of an app aimed at providing invaluable assistance to individuals and families dealing with the challenges of terminal illness and bereavement. Steve, I'll ask you to take it away from here.
Yeah, no, thank you, Phil. Appreciate that. I wanted to thank everybody for joining us on this KHAM webinar, and Julie and team at KHAM for giving us the opportunity to share the journey at Kern. I want to give an extra special thank you to both Edward and Amber for their willingness to share the journey that we've been on together over the past few years around prior authorizations. I'm just going to cover a few kind of just introductory items, and certainly I want to turn the show over to Edward and Amber to kind of talk about what they went through to help streamline their prior authorization workflows at Kern. And so maybe, Phil, if you can go to the next slide. Wonderful. I think for everybody on the call, this is kind of a little bit of we all live this every day, but just personally from my perspective, being a pediatric urologist, really began this obsession and passion about helping to try to solve some of the frustrations that we all have around prior authorizations, just out of seeing the day-to-day impact on the patients that I had. There were far too many kids that I remember that were dramatically impacted by the delays related to some of the prior authorization workflows that I know all of you live day to day. And so that's one of the big reasons for me personally as to why we need to figure out better ways to help get through prior authorizations. I don't have to tell any of you on this call likely of just the other aspect of just the challenges you all have with your staff and team trying to get through the work so patients can get seen. And certainly over the past several years, we've heard plenty about staffing issues, shortages, some of the high burnout rates related to some of the manual processes involved with prior authorization. So certainly this is on a lot of people's mind on how to start improving prior auth workflows. Next slide. This is just some information I think it might be useful just to have as a little bit of understanding at the national level. This is a recent report that came out earlier this year by an organization called CAQH. They are an industry stakeholder group represented both on the provider side as well as the payer side, looking at administrative transactions, including prior authorizations. And so some of the information here from the latest report, just to call out that struck my mind, was overall year over year, there's been an 11% increase in the number of administrative transactions that we all have to do, including prior authorizations. And some of that is from the COVID rebound, but also the increased requirements around the Medicare Advantage plans with their prior authorizations. The other set of information here is a little disappointing because I've been following this information for the past several years and it really hasn't gotten much better. And so we hope to do something to impact that. For prior authorizations across the country, of those surveyed, about 70% of these workflows are manual. I feel here in Southern California and California in general, it's probably much higher, just knowing the workflows with all the managed care organizations. And the average amount of time it takes to submit was about 22 minutes for prior authorizations at a cost of roughly around $11 per prior authorization. Next slide. So certainly having been in this process of helping prior authorization, challenges for a lot of organizations, these are some of the big areas of need that certainly we always get asked about. And so just to call out kind of what they are and kind of point to where we focus and what you hear a lot about in this presentation from Edward and Amber is auth determination. Is prior authorization required for a certain set of services? It may be a little bit more straightforward if you've got a heavy managed care Medi-Cal population like we did at Children's. So that's certainly one area, but the two other areas that we primarily focus on in some of the work that we've been doing with Kern and others is around auth submissions and auth verifications. They tend to be incredibly manual, going out to dozens of websites, managing fax forms still in this day, and of course, always fun sitting on hold forever for phone calls. And so you'll hear a lot about some of the work tremendous work that the Kern team has done to help streamline and automate these processes. And lastly, auth denial is another thing that we always hear about. So these are some of the frameworks that we certainly like to kind of approach helping organizations and clients work through. And without further ado, I think the stars of the show are really Edward and Amber, and some of the partnership that we've been on over the past several years in tackling prior authorizations. And I will turn it over to them with no further ado. Edward, I think you're on mute.
Can you hear me now? Great. I apologize for that. But thank you again, Dr. Kim, and to the Valer team and to KHAM for inviting us to participate on this webinar this afternoon. So I'd like to just share with you the journey. As Dr. Kim mentioned, we've been on this journey for a minute. We started this back in 2018 when Kern Medical embarked on trying to find an integrated solution to meet the challenges of complying with CMS rules regarding interoperability and patient access, and that is specifically the need to improve the health information exchange with a focus on an emphasis on treatment authorization, ensuring again that appropriate and necessary access to health records for both patients, healthcare providers, and payers were aligned. So several vendors were researched at Kern Medical. We were looking for a partner that was going to help us transform the existing authorization process and to ensure that the data was flowing securely and efficiently between Kern Medical and the payers. At Kern Medical, we, back in 2018, were using McKesson, or as you know it, Change Health, and we were in the process of migrating over to Cerner, and that took place in November of 2019. With that migration project, we had the majority of our IT resources allocated to the conversion, and so for a minute there we had to put the prior authorization project on hold. However, revenue cycle leadership here at Kern pursued the plan to secure the funding for the prior authorization solution. And we made a business case that I think was really compelling and important, making this a compliance issue and indicating that it would have been a missed opportunity for Kern if we didn't support the hospital's strategic priorities, provide an integrated delivery system focusing on improving the quality of care, as well as reducing some of our operating costs. And so putting Kern Medical in non-compliance was not an option. And then in June of 2021, post-Cerner implementation, the project appeared to be back on track. We had a service level agreement with terms and conditions that had been vetted out by legal counsel. We had secured the operating funding, garnered our board approval, and we moved forward with hiring a project manager to lead the project. However, we had this little thing called the pandemic that kind of stepped in the way, and the persistent demand on human resources once again caused the project to be put on pause. But I'm very pleased to say that in November of 2022, the hospital was able to automate and transform the prior authorization process with Valer, eliminating many of those manual activities that you're all familiar with and that we'll continue to chat about, automating the payer web portal submission and status checks, eliminated the payer fax forms by transitioning to extensive payer-specific and service-specific requests, being able to then provide real-time granular reporting regarding payer behavior and staff productivity, for example, and to provide a structured learning framework to reduce human errors and, of course, denials for both facility and ambulatory encounters. In November 2023, we celebrated our one-year anniversary, and to date, Kern Medical has optimized staffing by the derived operating efficiencies, moving to full-time FTE equivalents from our authorization team over to another unit within the rev cycle, so that we can continue to focus on streamlining. Turn it over to Amber.
All right. Thanks, Ed. So next, we're going to go over what our past state looked like, and this workflow might look pretty familiar to most of you. Again, we're Cerner Millennium users, but this workflow, if you're in a manual process, is going to look the same whether you're in Epic or Cerner or any of the other EHR systems. So basically what would happen prior to us streamlining is that once the account was scheduled, and we're speaking to non-urgent, non-emergent cases, once the account was scheduled, it would drop into our prior authorization work list within Cerner. The rep would go into the encounter, and depending on the payer that was listed in the account, they would then navigate to the various payer portals, log in, and initiate the authorization process. Once the authorization was initiated, the passer, the patient access service rep, the passer or the rep would then go back into Cerner, update that authorization field showing that the authorization had been initiated, log their documentation of the processes that they had completed, maybe scan in any documentation that they had to, and then they would move on to the next encounter. Now the hiccup is, or where the real mundane process is that all of these pending encounters need to be followed up on. So that means the rep then needs to circle back and log into all those various payer portals, check those statuses. Once the final status is received, they go back into the patient's encounter, they flip the authorization to approved or denied or whatever the final status was, scan in any final documentation, and then they would finally be done. But the problem with this process, not only is it super tedious, but there's a lot more problems that could be encountered during this process. Maybe there wasn't a payer portal to log into, and now we have to make phone calls to start that authorization, which that in itself, those phone calls used to be on hold for hours. Maybe that wasn't a phone call. Maybe we had to manage a faxing authorization process. So there's just so many things, even though the manual process in and of itself was difficult and long and time consuming, but then you have to factor in all of the problems that could go wrong in those manual processes. So it's a huge draw on our resources and our team's productivity overall. So next, I want to move into our current state. If you can go to the next slide. So current state, first and foremost, what you're looking at here, number one, it's significantly less steps than what the prior state was. But what I want to point out is that in current state, the blue tiles that you see are all of the processes that are now automated. So the only manual processes that we have are the orange tiles that you see. So the account is still scheduled. But what happens after the encounter is scheduled in Cerner is that Valer, our automated authorization tool, automatically for us pulls the encounter from Cerner into their authorization dashboard. So the passer would then go into their authorization dashboard in Valer. They would open up the patient's encounter. And what Valer has done is that not only has it just pulled the encounter over into their dashboard, but it's also pulled in the patient's data, the patient's insurance, the name, the date of birth, all of the supporting information that we're going to need to submit that authorization has been pulled over by our authorization tool. So what the rep would do is they would just validate quickly that all the information is correct based on what Cerner has. They might need to go into PowerChart, which houses clinical documentation, maybe images, and if anything was needed to support that authorization, they would import that from PowerChart into Valer, and then they would hit submit. And that, taking it from logging into Cerner, logging into the payer site, calling the payer, starting the authorization, we've taken it from all of that to going into Valer, making sure everything's correct, maybe uploading results of a CT scan and hitting submit. Once the rep or the passer hits submit, Valer submits that authorization for us to whichever payer portal it happens to be. The cool thing is, I mean, that was all kind of cool to begin with, but the cool thing is that Valer then takes it from there. Our rep moves on to the next encounter after that process. Valer, on a scheduled cadence, will call out throughout the day to these various payer portals asking for status updates. Once it receives the status update, it's going to open the account in Cerner, and it's going to update the encounter showing the final status. It's going to also upload what we call an authorization packet. In that packet includes any screenshots from the payer's website showing that the authorization was approved or denied, or whatever the final status is. And it's going to upload that into the patient's encounter. It uploads it in two different apps that we use with Cerner. It uploads it into PM Office as well as PowerChart. And I think the cool thing about that is that the doctor's office might be using PowerChart, HIM might be more using PowerChart, maybe billing might get into PowerChart. They all need access to this authorization at one point or the other. So it's uploaded into both systems for us. We don't even have to do that. And then all of the documentation, all the notes is also uploaded into the patient's account showing what the final status was. So we've taken it from, 8 to 10 steps down to 3 steps that the pastor has to take manually. So it's cut down a significant amount of time that the reps are spent logging into these portals. It manages all of our portal logins for us. So initially when you set up your rep's account, they enter all of their login IDs and it houses all of that for us. It also stamps the authorizations that we submit with the rep's name so we can see who's submitting the authorization, for visibility and all that. So it's such a clearer, cleaner process than it was when it was manual. And again, as Ed said, we've been able to relocate 2 of our staff to other processes and other areas that we might need additional staffing in. So it's kind of freed us up in that way as well. So from here, I'm going to turn it back over to Ed, and he's going to go over basically what streamlining means for prior authorization and kind of speak a little bit more on a deeper level on that.
Thank you, Amber. Well, I think the slide kind of speaks to it. Having a smooth running system, kudos to the Valer team. They have solution architects that have been readily available to the team, when there has been a question or a concern about what was submitted or not submitted and what the actual response is or needed to be. The solution architects in real time can answer and address the issue without having to submit a service request to the vendor and wait for someone on the solution architect side to respond days or weeks after the fact. So again, it runs really smooth. We haven't had any downtime, and we're very appreciative of that. Second, the time savings, the amount of time that the staff have had to spend in navigating 2 systems has really just improved our operating efficiencies. And again, using this push technology to scan the authorizations directly into the patient's profile has been really useful, especially for our revenue integrity team who might be having to work a denial and work on the appeal to get that encounter resolved. Refining the process, again, as Amber pointed out, all those steps in the manual process have just really been a great improvement. And we'll talk about this a little bit toward the end, reducing the denials for claims with the missing CART code, in particular the 197s that are attributed to the front-end rev cycle patient access team. So, when we talk about operational excellence, first, we have to recognize that there was an opportunity for our pre-services team to improve and streamline the auth workflow. And we became resilient in the face of the adversity that I mentioned early on, adapting to the challenges at hand, teaming with our business partners at Valer to grow from the experience together. We set realistic short-term and long-term goals, tracking our success, showing interest in our teams, and recording and sharing our progress and our hopes for our collective futures. We're still a work in progress, continue to become strategic leaders, planning for the next iteration and influence and guided by our shared values and our experiences. So for us, streamlining the prior authorization process meant, setting the goals where we needed to be, finding a solution that was efficient, user-friendly, and in line with compliance guidelines. And so the solution needed to demonstrate measurable KPIs and validate the return on the investment. So if you're looking for a solution, again, take those issues into consideration. I think that the manual authorization process, as we all know, and Amber mentioned, is quite tedious and can be lengthy. We've been there. You've got all the variability in processes that we talked about, and streamlining is the way to go and to shift away from these antiquated processes, from manual auth submissions to an integrated solution that's going to save you time, resources on the labor side, and dramatically increase your productivity and your authorization clearance metrics. So next slide.
All right, so I'm going to take it from here, go over benchmark improvement. I tend to get a little excited when it comes to numbers and reporting and all that stuff, so forgive me. So as far as benchmark improvement specifically related to the auth resolution rate, first and foremost, we always target to use NAHAM's access keys as our standard of benchmarking of where we need to be. So according to the NAHAM access key CP2, or the auth resolution rate, a good benchmark is equal to 70% as far as auth resolution rate goes. So you can see on the slide that prior to streamlining, we were only at 68% auth resolution rate. So we were even below a standard of good as far as benchmarking goes. So as the opportunities to streamline and increase efficiency are identified, such as in the area of prior authorizations, what we'll do is we'll review our current state and what we're doing against NAHAM access keys to kind of set a course of where we need to be. And then also on the side, you can see that after we went live with our authorization solution, we're actually above an excellent rating at 97% on average, give or take. So I can't speak highly enough to the automation process and not only what it's done to free up our staffing, but to take us to an excellent benchmark as far as national standards goes. I think it speaks pretty highly for itself. But so following the NAHAM access keys as our benchmarking standard, what we do is we take those benchmarks to establish our KPIs, and then we'll use those KPIs to kind of measure our operational departmental outcomes against those national standards to kind of show not only where we were, but how far we've come. So to get that auth resolution rate, according to NAHAM's best practice recommendations, that auth resolution rate formula is established by dividing the total number of encounters that require an authorization by the total number of encounters that were approved or authorized. And then it's important to know that when you're working on your formula to kind of see where you fit in all that, don't count any authorizations that were obtained retrospectively during the denials management process. You really only want to include those authorizations that were approved prior to service. So also NAHAM has recommendations. So if you guys are looking into Valer or an authorization solution, NAHAM recommends that there's certain guidelines that your automated authorization solution should adhere to. The first of those recommendations is that your solution, your automated solution, should continually track and identify encounters that are going to require the authorization based on the scheduled service type and those payer contract terms. So the second guideline that they suggest is that once those encounters are identified, then your solution should also continuously notify your staff of the authorizations that are required, and as well as tracking that account through the resolution process. The final recommendation that NAHAM suggests is that your automated solution should be reporting out its metrics on a monthly, quarterly, and annual basis. And to ensure maximum accountability, the solution should also report out on 4 different levels: the facility level, the location level, the payer level. And in my opinion, one of the more important levels is the employee level. So it's important to know how we're getting the authorizations and how many we're clearing for different locations to show, our ordering physicians that we're getting our surgeries approved, or we're getting our outside radiology approved on a frequent basis. But it's also really important to be able to track and trend maybe payer behavior. Maybe you're struggling with, in California here, our HMO system can be a little wild at times. So be able to track and trend payer behavior based on the different payers that you're getting those authorizations for can be really helpful, even speaking to your denials processes. But being able to report down to an employee level, I find as a leader is extraordinarily helpful. It's great to be able to tell your team how you're doing, and it's wonderful and I think very necessary to be able to report out to upper leadership your ROI and how the service is performing. But to tell your employees on an individual level how they're performing, do we have educational opportunities? Do we have process opportunities? Are you within the standard of productivity? Do you need a little assistance? Being able to give that really positive, very detailed, data-driven feedback is key. And I can't speak highly enough for it. So that's kind of what we're looking at as far as the benchmark resolution. I mean, I think the numbers really speak for themselves. It's incredible what we've done.
So back to me. Thank you, Amber. We talked a little bit about operational excellence, and productivity, eliminating those time-consuming manual processes, and efficiency, having those real-time decisions coming back through the application, and again, reducing or eliminating the use of those outside portals by having this one, efficient tool that processes those authorizations quite efficiently. I can't speak to it enough. And then ultimately the reporting, that the vendor provides real-time insights into the auth processing. We get those status reports out and back into the system, again, in short order, giving us, an opportunity to look at the data and make any decisions that we need to make. So I think all of Amber's insights and what she just shared, is relevant, and I'm sure those that are participating on this webinar can relate to those challenges. I will say, though, that when we come to reporting and denials, just to tie back to that last slide regarding the KPI improvements that Amber pointed out, prior to automating this solution, 68% was our auth rate that she mentioned, and our denial rate was about 17%. And as she also mentioned, if you look at our KPIs today, we have a 97%, auth rate, and our denials are at approximately 2%. And just to give you some new numbers, for the month of April here at Kern Medical, when we look at CART code 197, those denials that are attributed to, no pre-cert or no auth, we identified 59 encounters for just over $476,000. So again, we've come a long way. It's been a journey. Fortunate to have Valer as a business partner for their support. We're very much appreciative. It was a labor of love, and resilience, starting back in 2018 to where we are now. And I look forward to continuing the partnership and assisting anyone who has any questions or concerns about how to go about developing an integrated process so that you too can experience what we've been able to experience here at Kern Medical. So thank you.
Appreciate it. And just to add on from our lens and perspective, I think part of what Edward and Amber really had was a clear vision, which has been very helpful in terms of planning the process and getting these results. Like Ed said, this was both everybody, all parties involved, rolling up our sleeves together and continuously grinding and working at this to get them to the results. And so it just really incredible joy and kind of some of the results that all the teams can be very proud of, and kind of putting in the hard work and effort, but being very methodical about how going about that process. And I would encourage any of you to reach out to Edward or Amber. I think one of the things that Edward and I discovered that we share in terms of a philosophy or mantra is the failure to plan is a plan to fail, right? And so I think none of this is magic silver bullet, and the two on here will definitely say this is like a partnership, right? And I think that's kind of what it takes to get to the results and the success that they have. And a real kudos to both Edward and Amber, but also all their teams, right? This was definitely a team effort, and certainly from our perspective at Valer, we're incredibly proud of the work that has been done to help get them to where they are. And as Edward said, there's a lot more opportunities down the road as well. So I really want to thank you both for being such great partners along the way.
With that, we've got a few questions rolling in. Steve, I'll pose this first one to you, which is, does Valer work with other EHRs outside of Cerner?
Yeah, we certainly do. We work with Epic. We're part of the Epic app market. So for those folks who happen to be on Epic, we've got nice sets of integrations there. We also work with other EMR platforms, Athena Health, NextGen, the Veradigm platform. And so we do have a broad scope of different EMR platforms to work with. Even a system like Cerner, obviously, we all know that there are different versions, so we have familiarity with the different configurations. But one of the things we've always done in kind of one of our core capabilities, working with IT teams to build out those integrations. And you heard a little bit from Amber and Edward about how incredibly useful and efficient it is to not have to have people type stuff back and forth in. That's part of the value proposition. So for sure, and happy to discuss with you, Gentry, if you have any specific questions, either offline or via email.
Amber, you mentioned the NAHAM standards and the benchmarks to which you're comparing Kern Medical's performance. Don't know, I don't want to put you on the spot here, but I don't know if you can comment on the formula for the NAHAM standards itself. I know you mentioned
so
ratio earlier.
It's authorizations required divided by authorizations obtained. So just to go into that a little bit more, when you're looking at your authorizations required, I typically will filter out anything that doesn't require an authorization, anything that my staff can look at and go, well, based on this pay or based on this service, it's not going to require it. Really, it's truly only anything that would actually require an authorization divided by the authorization obtained. And that could be approved in a pending status, but approved, I know those are not too common, but just anything that got an approval by anything that needed an approval. So, and I think my email is included in that slide. So if you want to shoot an email my way, I can give you a little more information, and I can send you a link to access NAHAM's access keys, as well as any other information on that data point as well.
And maybe we can even put some references that we can circulate with some of the NAHAM access keys and the formula and the metrics that you utilize for the CPT metrics. So
this next question is from Lena, and I may ask actually all three of you this question, or at least the Kern team and Steve, because I think you'll each have a perspective here. And the question is, can you speak more about the business case that you made for your leadership approval with Valer? And maybe Edward, if you want to speak first to that, or certainly Amber, if you want to contribute there as well. And Steve, you might follow with a broader perspective on how, when we speak to prospective clients, how they might think about that as well. You want to start,
Phil?
Yeah.
Yeah, thank you. I'll take that question. Developing a business case was a bit challenging. In healthcare, of course, folks are prioritizing where they're going to expend their resources. Is it going to be at the bedside, with focusing on patient care, patient safety, technology that can be, better served working with the clinical side of the house. And I thought that, again, understanding what was coming down the pipeline with the proposed CMS rules And again, this was back in 2018. The rules have gone through several revisions, get to where they are now, but I made it a case that it was compliance and we needed to have a solution. And therefore, we should allocate the resources to bring on this automated and integrated solution because there would be that ROI on at the end of the day, not only just in managing your labor and the expenses associated with prior authorizations, but again, from a regulatory compliance perspective. And so once I was able to get that message through, again, as I mentioned, having legal understand that there were going to be implications if we didn't do this down the road when it came to CMS audits regarding compliance and interoperability, much more than just teaching patients how to access the patient portal or having our providers in the community share data. We needed to have an integrated automated solution for prior authorizations, and feeling very confident. We proceeded forward and were able to garner, like I mentioned, board approval. And I tell you, funding it from an operations standpoint, there was some push and pull from the IT team. They didn't claim to have resources, so I made a deal with my CIO that I would take a couple $100,000 out of my operating budget, to pay for the project manager, and so meeting with the CFO, we made that deal or that decision, and the rest is kind of history. So I hope I answered that question, Lena, from the facility side.
That's great, Edward. Thank you. Amber, do you want to add anything, or Steve, from a Valer perspective?
Nothing from me.
Yeah, I mean, certainly we have a lot of conversations with different organizations, and in building the business case, there are usually a couple of major factors that factor into it. One is just the pure amount of staffing requirements related to the manual process. And so one of the things that we've done on numerous occasions is help work with kind of map out what are the volumes, what are the estimated times it take, and then really from our experience and history at places like Kern and other places, kind of mapping in what is the reduction in staff requirement time, right? So to get through the same amount of work. And so there is an ability to calculate that. As you heard from Edward, many of our organizations we speak with are reallocating resources to other priority projects away from just doing the manual work for prior authorization. So that's generally been one of the strong cases and arguments being made. I don't know about organizations that you all work for, but staffing shortages have become pretty common that we hear about, of just finding ways to recruit and retain for pastors to do the work has been more and more of a challenge over the past few years, especially in light of COVID. And so we frequently run into organizations that have a need, they can't get through the work, and they have open positions and are just not able to find the staff to do the work per se, but we offer an opportunity to actually be able to do the same amount of work or more with the staffing that you have. And so that's been another kind of ROI point. The other major point, which is a kind of an economic point that a lot of our prospective clients and clients will look towards, is that prior authorizations is usually one of the top reasons for denied claims on the back end, and it's incredibly expensive and difficult to go through the denials management and appeal process. And so, as Edward pointed out, our philosophy is if we can actually reduce the amount that goes into that denied bucket and the write-off bucket, that's a financial win for the CFO and the organization from a revenue cycle perspective. So, every organization starts at a different place is kind of our experience in terms of where they are at with that. But from my perspective as a physician, if that's services that we performed and we're not collecting, those are kind of precious dollars that can get that could have been collected potentially, and those denials could be avoided. Those are things that we kind of work with organizations to help quantify if available, right? And so between those two major areas, it tends to be a pretty high focus area now. We're hearing a lot of organizations actually reaching out to us around finding better ways to manage and deal prior authorizations. And then to Edward's point, there's a lot of legislation that is recently come out. CMS has recently passed the final rule for prior authorization. Much of it is focused primarily on the payers, making them start publishing more transparent metrics of what requires auth, as an example. But there are other states, not necessarily California yet. I know California's legislature has been working on this, where, like the state of Texas, for example, gold carding is another concept where if providers are getting approved 90% plus of the time for the past 9 months or 12 months, that authorization should be removed for that specific provider. So those are areas that we know are coming down the pike and meaningful for organizations depending on where you live and what state you're practicing in. But that type of data is really hard to come by. To Edward's point, if you don't have some form of a solution in place to actually be able to make it easy to collect and capture that information. So those are other areas, other aspects. We get a lot of interest from managed care teams and contracting teams because there's data that Amber alluded to. We've got pretty discrete information about exactly what the payers are doing in terms of the turnaround times, what they're approving and what they're denying. And frequently, if you're in certain states where there are rules about turnaround times, this is all information that the managed care contracting teams can go back to at the JOCs to bring that to attention. So those are just some examples that we've come across. Generally speaking, there's also thematically a lot of the managers and directors we work with, they feel like their team members are in a much better mood and not having to spend all this time manually cranking through prior auths. And so there's a staff morale aspect to it. And we're probably going to work to do a better job of quantifying that over time as well. So those are some of the things that we've actually worked on with other organizations to help make the business case for a prior authorization automation solution.
Thanks, Steve. Annette asks a follow-up question. Does this also tie into estimate letters based on the No Surprise Act? And that what she means by that is automated copies go out to patients.
Yeah.
Before I'll ask anyone to answer this, I will make a little plug for a webinar that Valer is hosting on prior authorization legislation next month. Again, this is very germane to what we're talking about here. We'll cover various aspects of both state legislation as well as federal legislation. And that webinar will be taking place on June 13th in about a month. You'll see emails for that. Should be going to all of you here shortly. Steve, I don't know if you have any other perspective to add to that to build on Annette's question.
Yeah, I mean, understand kind of the price estimates going out. And we've been asked about the ability to do that. One of the things that we have a lot of core competencies in is automated form generation and to be able to send information out. Now, we don't quite do that at Kern yet, but we do have the ability to send out automated pre-populated fax forms for estimates, but we do need the information from your source systems to set up the automation to go out if that's the case. With other clients, we do have integration with their patient SMS text messaging system to at least provide information. So there are opportunities. We don't currently do that to answer your question directly, Annette, but we are certainly getting into this phase where we're being asked to do more around sending out notifications. So certainly would love to talk to you more about learning the challenges around that and see what there might be able to be done with what we've built on our platform today to help support that. So, but certainly we don't have the ability to come up with the information. If you have it in your price transparency estimators and you would like us to create an automatic generated letter, those are things that we can do. We don't do snail mail, but we do a variety of different ways to get that out to people. So,
thanks, Steve. Edward, do you want to add to that?
Yeah, I was just going to mention that our contact information is on the screen. Here at Kern, we do meet the No Surprise Act compliance. We have that as one of Amber's KPIs that she loves to track and report out on. We are, generating those good faith estimate letters for both our self-pay patients and our commercial payers, whether they're contracted or not contracted. And we've been quite successful at that. So if Annette wants to shoot off an email to either myself and or Amber, we'd be happy to get back to you with some additional information. I mean, sharing is what this is all about. So thank you for the question.
Unless we have any other questions, and we'll give it a minute. Julie, I think you probably
Yes,
want to wrap up, right?
I do. Thank you so much. Well, first of all, I want to thank everybody that joined us today from our KHAM membership. And I want to thank the Kern and Valer teams for presenting today. Great information. And then I want to remind everybody that on June 20th, we're going to have Deb Benchowski from Uprights Consulting give training on intermediate Excel. That is June 20th at noon. Other than that, everybody could see the information for Dr. Kim, Amber, and Edward. Their contact information. We'll have this up on our KHAM web as well. And I just want to say thank you so much to everyone.
Thank you, Julie.
You bet. Thanks, everyone.
Thank you.
Thanks, Julie.
All right. Bye-bye.
Bye.